So, as we all know, neurology or is the study of the nervous system of the brain, of the body, which includes the brain, the spinal cord, and all the other organs of the body from where the nerves originate. Now, neurology is studied separately as an entirely different entity. Immunology, on the other hand, is the study of the immune system or the defense mechanism of our body, which is also studied autonomously. And in recent times, it was considered that these two systems are totally different entities which work autonomously. But recently, it has been found that the link between the nervous system and the immune system is quite important for maintaining the homeostasis of our body. Now, how is it so? It has been found that the microglia and the neuron are essential for maintaining the homeostasis, and also the link between the microglia and oligodendrocytes is essential for maintaining the homeostasis of our body. Next slide, please. Thank you. So before we move to study anything, we must know how it all originated. So neuroimmunology originated by an accident. I would say all the major discoveries which have been done till now, they all started accidentally. So how it all started? The involvement of the immune response in the neurological diseases can be traced back to the 1940s with the development of an adjuvants for inducing the clinical diseases in animal models for the better examination of the diseases and their causative agents. Now, what does that mean? Researchers back then, they were trying to identify how the various diseases and their causative agents act in different animal models. And so what they did, they induced the adjuvants into the animals. Mostly they were rats. And some of the examples are like experimental autoimmune encephalitis or EAE, experimental autoimmune neuritis or EAN, which were induced into the animal models. And the injection of the antibodies, acetylcholine receptor, AChR, and from the patients with myasthenia gravis or MG, induced experimental diseases in rabbits. So these were the successful trials. The therapy used for antibody-mediated diseases included the plasma exchange, while broad immunosuppressive approaches, for example, the adrenocorticotropic hormone, were implemented for multiple sclerosis or MS, which was then later approved by the Food and Drug Administration or FDA in the year 1978. And from there, neuroimmunology began to be studied as a whole new entity. Next slide. So the most beautiful thing about this subject is that it keeps on evolving. You never know the complete thing, and there is always a scope of knowing more and more new things. So the slide titled "What We Know Till Now and What Lies Ahead" is totally based on that. What is the future of neuroimmunology? So the accumulating evidence during the last 2 decades have shown that there has been a senescence of the immune system with the late onset of neurodegenerative diseases like the Alzheimer's disease, Parkinson's disease, spinal cerebellar ataxia, amyotrophic lateral sclerosis, and the Huntington's disease, which hence broadens the range of diseases falling within the neuroimmunological field. While the current therapies aim to modulate the neuroinflammation arising during the diseases, the future approaches must aim at disease prevention. Now, with the advancement in the medical sciences and the biomarker research, it has been quite possible to diagnose the diseases faster and monitor the clinical trials more effectively than what it used to be some 40 or 50 years back. which has definitely speeded up the drug development and reducing costs. The biomarkers of the neuroimmunological diseases may include markers of the blood-brain barrier disruption, demyelination, oxidative stress, and excitotoxicity, axonal or neuronal damage, gliosis, remyelination, and repair. But it should also focus on markers of, of sorry, it should also focus on the markers of the altered immune function, such as the cytokines, chemokines, etc. Also, in the early 21st century, we have seen that the study of microbes have been, there has been a huge advancement in the study of microbes with the newly emerging the Zika virus, Ebola virus, and the coronavirus, etc. And thus, the link between the gut microbiome, influence susceptibility to the neuroinflammatory diseases have been studied. In line with this, trials have been highlighted the need to develop more specific approaches in the neuroimmune diseases other than broad immunosuppression or blocking cells from entering into the central nervous system in order to avoid the emergence of opportunistic infections. Now, there have been very recent advances to the various therapies, such as the cell depletion therapies, for example, the B cells in the multiple sclerosis, tolerance-inducing strategies, and the use of stem cells have been a major focus in multiple sclerosis. While gene therapy approaches have been initiated, it can be a possible future of the what should I say? It can be a possible future of the multiple sclerosis or the amyotrophic lateral sclerosis. Now, I would like to hand over to Ruchita, who will be speaking upon the practical applications of the neuroimmunology, that is the neurological infection. Next slide.
Thank you, Narendra. A very good evening to one and all present here. So, today my topic of discussion will be on neurological infections. So, what do you understand by the term neurological infections? Neurological infections encompass a large variety of conditions that invade and affect the nervous system. Viruses and microorganisms sometimes invade the body, infecting various organs and causing everything from mild disturbances to causing very serious problems. Bacterial organisms are often to blame, but animal parasites and fungi can also cause the infections. The neurological infections can occur when these viruses and organisms invade the nervous system. There are several factors that contribute to the widespread incidence of neurological infections, such as firstly, the rising number of people who are infected with the HIV or AIDS. Why? Because they are susceptible to the neurological infections due to impaired immunity. Secondly, the increasing use of immunosuppressant medications such as the anti cancer drugs that leave the people vulnerable to the neurological infections. Thirdly, several viral infections of the central nervous system have emerged that are not yet amenable to available treatment. Let's focus on the neurologic complications of human immunodeficiency virus infection or HAND. The HIV infection itself can affect any part of the nervous system at various points during the course of infection through a number of mechanisms, including toxic effects of the viral proteins and low level chronic inflammation, which is induced by the infection. HIV associated neurocognitive disorder or HAND remains one of the most common neurologic complications of HIV encountered today, but milder forms predominate in the people who are on ART. The HIV associated neurocognitive disorder or HAND represents a spectrum of conditions of varying severity, which includes from mild to most severe. Asymptomatic neurocognitive impairment, mild neurocognitive disorder, and HIV associated dementia. The widespread ART use Hand continues to affect up to around 50% of the patients with HIV and remains one of the most common neurologic complications of HIV encountered today. And before the ART era, HIV associated dementia occurred in up to 20% of the individuals with acquired immunodeficiency syndrome or AIDS and was almost always fatal. Next slide, please. So, we will be focusing on briefly on three types of the neurological infection. Firstly is the encephalitis. It is an inflammation of the brain which can be caused by either bacteria or the viruses. The second one is meningitis, which is the inflammation of the membranes that cover the brain and the spinal cord, which can be caused by either bacteria or viruses again. The third one is HIV, which is a viral infection that causes AIDS and gradually destroys the body's immune system. Ghazal, next slide, please. So, unlike the cortical dementia, such as Alzheimer's disease, hand is a subcortical cognitive disorder with prominent psychomotor retardation and motor symptoms that includes the incoordination and balance impairment. However, in the ART era, executive dysfunction, learning impairment, and problems with the memory encoding and retrieval are becoming more prevalent. Hand can develop at any point during HIV infections, including in mild stages of immunosuppression, but lower nadir CD4 plus T cell count and a history of AIDS remain significant risk factors even in the patients with this HIV infection who are on ART with optimal virologic suppression. The diagnosis and the classification of hand are based on the magnitude of deficits detected on the neuropsychological testing and functional status assessments. As with other cognitive disorder, diagnosis of hand should not be made in setting of an acute illness in the stable patient who is HIV infected and presents with cognitive symptoms. Several hand screening tools are available and easy to administer in an outpatient setting, including the HIV Dementia Scale, or also known as HDS. Let's focus on a case study where a 40-year-old woman was presented to the clinic with cognitive concern. She was diagnosed with human immunodeficiency virus or HIV 10 years previously and had been on a stable antiretroviral therapy or ART regimen for the past 8 years and had an undetectable plasma HIV RNA and a CD4 plus T cell count, which was much greater than 500 cells per millimeter cube. Her past medical history was also significant for type 2 diabetes mellitus and tobacco use. The neurologic examination was notable for slow finger tapping, saccadic interruptions of smooth pursuits, and a prominent snout reflex. The brain MRI revealed symmetric confluent subcortical leukoencephalopathy without enhancement and mild generalized cerebral atrophy. There are two pictures given out here. So look at these two pictures of MRI. The left one shows the MRI of the normal brain, whereas the right one shows the MRI of the person that is infected with the HIV virus. This patient likely meets criteria for minor neurocognitive disorder, as she described mild to moderate cognitive symptoms that have negatively impacted her daily function. She has several risk factors for HIV associated neurocognitive disorder, including a low count of CD4 plus T cell count, tobacco use, and the diabetes mellitus. Further, no adjunctive treatment is currently available for hand, but the patient may get benefited from the cognitive rehabilitation. In addition, her caregiver should be aware of the cognitive deficits so that they can provide some extra support with complex tasks and ART adherence. Ghazal, next slide, please. So let's talk about some other neuroimmunological infection. Firstly, it's the Bell's palsy. It is a condition that causes sudden weakness in the muscles on either side of the face. In most cases, the weakness is temporary and significantly improves over the weeks. The weakness makes half of the face appear to droop. Smiles are like one sided, and the eyeball or the eye on the affected side resists closing. In the patients with risk factors of HIV infection who present with the Bell's palsy, both an HIV antibody test and plasma HIV viral load should be considered, as this condition often presents before the seroconversion, or that is the HIV antibody test remains negative. So there are certain signs and symptoms of the Bell's palsy that come on suddenly and may include the rapid onset of mild weakness to total paralysis on one side of the face that occurs within hours to days, the facial droop and difficulty making facial expressions, such as closing the eyes or like smiling. Thirdly, drooling is also a sign and symptoms of it. Pain around the jaw or in or behind the ears of the affected site. The second most important neurological immunologic infection is the HIV associated myopathy. The HIV associated myopathy occurs anytime during the course of HIV infection and usually present with slowly progressive proximal limb weakness with or without myalgia. The etiologies are varied and they include the direct toxicity of HIV infections. The creatinine kinase levels may be mildly to markedly elevated. The serologic testing for other infectious etiologies and a muscle biopsy are indicated. The treatment for this HIV associated myopathy includes the discontinuation of zidovudine and initiation of an alternative ART regimen again, or the immunomodulatory medications in inflammatory subtypes. Ghazal, next slide, please. And lastly, the motor neuron disease. It is an amyotrophic lateral sclerosis like syndrome that has been reported in individuals who are HIV infected and often improves or resolves completely with the initiation of ART. The syndrome occurs at a very younger age compared to individuals with amyotrophic lateral sclerosis who are not on HIV infected and may be related to the expression of endogenous retrovirus or HERVK. The physical effects of motor neuron disease can include muscle cramps or aches, twitching, weakness or changes in hands, arms, legs, voice. The person may also feel fatigue, muscle wasting, or weight loss. There are causes of MND or the motor neuron disease, which is not known, but worldwide research includes studies on the exposure to the viruses, exposure to certain toxins and chemicals. Genetic factors may also stand as one of these. And lastly, the nerve growth factors. So here is the picture of Stephen Hawking, who was the victim of this motor neuron disease. Next slide, please. So further, the topics of neurosurgery will be discussed by Mr. Narendra Singh. Thank you.
Thank you, Ruchita. Now, as the title of the conference itself is neurosurgery, I would like to start off with the history, how it all started, and some of the recent findings, which I find that it can be the probable future of the neurosurgery. Next slide, please. So, the history of the neurosurgery. It all started back in the ancient Roman Empire uh, by with the coming of the head surgery, if I can use that term. It's commonly known as the trepanation, which was then thought to be a treatment for various ailments such as the head injuries. And it was also used to treat pain, like they would literally drill a hole into the skull. And it was also sometimes a bit peculiar because if some human being was behaving if a human being tends to behave in some abnormal manner, trepanation was also then performed, which was thought to pull some evil spirits from the body, which was a superstitious practice, of course. So trepanation, right now, I do not know what effects did it have, but it has been found that it has been used to treat pain and the pain used to get cured. So it's strange, but it's true. Next slide, please. Okay. So coming to the interesting part, which I found very interesting, is the use of 5-ALA or 5-aminolevulinic acid mediated distinction of the low-grade gliomas and its use in neurosurgery. So what happens? Glioma, as we all know, is the tumor of the brain, and 5-ALA is a chemical compound. What happens is that when these compound comes into contact with the malignant glioma cells, it then undergoes a heme biosynthesis pathway and gets metabolized to form protoporphyrin 9, which is a fluorescent metabolite. It is some a deep blue or violet color in nature, which fluoresces very heavily, and it helps in the distinction of the cancerous cells and the non-cancerous cells. The speciality is that the metabolism is only seen by the cancerous cells or the glioma cells, not by the normal cells. And previously, it was found that 5-ALA was only seen in the high-grade gliomas. But recent findings have shown that 5-ALA mediated fluorescence is also seen into low-grade gliomas or the tumor of the brain, which are at the very earliest stage. So how is it of good to the neurosurgeons? As we have some of the experienced neurosurgeons sitting over here, there are some very various dyes like the indocyanine green or the trypan blue or the brilliant blue G, which is definitely used for fluorescence or the staining of the different tissues. Uh, the 5-ALA dye, it fluoresces very brightly, which makes it very easy and feasible for the neurosurgeons to work for. So this is, of course, one of the greatest findings which I found, which can be a probable future in treating low-grade gliomas as well. The work is being done right now. It's under progress, which will be completed hopefully in the coming years. Next slide, please. Yes. So the second important part of my talk will be on the mental disorders or the brain disorders, and the major focus will be on the PTSD or the post-traumatic stress disorder. Now, how does trauma affects the brain? It's of course not the physical trauma, but the trauma or the memories associated with some traumatic events which may have occurred in the past. It can be due to violence, it can be due to anything. So how it all affects the brain? Now, there are three major important regions of the brain which are impacted by the trauma. The first is the amygdala, which is responsible for the emotional and the instinctual center of the brain, which is the emotional and the instinctual center of the brain. Now, what does that mean? It means that if there is any traumatic incidents going on, amygdala starts thinking differently. I mean, it gets overly sensitive and its activity increases because it is responsible for the emotions, that particular part. The second important region is the hippocampus, which is responsible for the memory and differentiating between the past and the present. Now, what does that mean? hippocampus is totally responsible for storing memories. Suppose if I have an exam tomorrow and I'll be studying, uh, I have been studying for past 5 to 6 months or for past 1 year. It The role of the hippocampus is to store the entire thing which I have studied. So that makes the hippocampus very crucial. The third important part is the prefrontal cortex, which is responsible for the regulation of impulses and emotions. Now, what makes it important? The prefrontal cortex is responsible how we act, how we respond to various emotions, be it anger, be it grief, be it joy, be it anything, how we are responding and how we are uh, controlling our impulses. So the prefrontal cortex is responsible for all that. Now, how does trauma affects? So as I also mentioned before, the amygdala activity increases with the prolonged trauma because it is responsible for emotions. So a trauma means an overflow of emotions and hence overactivity of the amygdala. The second part is the prefrontal cortex, which is responsible for controlling of emotions and the impulses. So the prefrontal cortex activity, it decreases because if there is an overflow of emotions, the control has to be low. Like the control over emotions decreases, and so does the activity of the prefrontal cortex. Now, the third important part around which the entire thing revolves, the entire study revolves, is the hippocampus. Now, what happens is that with prolonged trauma, the hippocampus fails to determine what's present and what was in the past. And if there is, if suppose if you have been through a traumatic experience some 2 or 3 years ago, and if the memory is being recalled, the hippocampus will act as if the trauma is occurring right now. That means it fails to distinguish between what's past and what is present. And with consistent exposure to trauma, the hippocampus gets smaller in size, which have been found in patients with major depressive disorders or the, what should I say, this post-traumatic stress disorder. It has been found that the hippocampus has been reduced. There is an atrophy of the hippocampus. Now, is there any treatment to this? Now, of course, the brain has the ability to heal itself on its own. A term known as neuroplasticity is generally used, which is the ability of the brain to form new connections, which rewires the brain to reverse the trauma's damaging effects. So the healing process is undoubtedly very slow, but the brain can heal itself over time by the action of neuroplasticity. So that's all. The next slide is one of the most important findings about what if the hippocampus is not able to heal itself. Now, the abnormal interactions between the amygdala and the hippocampus and the MPFC, which is the medial prefrontal cortex, are thought to underlie the PTSD or the post-traumatic stress disorder, resulting in the over-consolidation of the fear-based memories or abnormal interactions between the amygdala and the hippocampus and the medial prefrontal cortex are thought to underlie the post-traumatic stress disorder, which results in over-consolidation of fear-based memory, weakened fear extinction, which is the decrease in conditioned fear response, weakened fear extinction, which is the decrease in the conditioned fear response. The pathogenic mechanism is thought to be a process of fear conditioning marked by amygdala hyperarousal and reduced medial prefrontal cortex activity, resulting in impaired extinction or reduced hippocampal or parahippocampal activity is also implicated, resulting in overgeneralization of the fear to non-threatening stimuli and inability to differentiate safe and threatening objects. Now, even after all this, what if the hippocampus is unable to heal itself? Like we know that, as I mentioned in my previous slide, that there is an atrophy of the hippocampus in patients with the post-traumatic stress disorder or prolonged trauma or the major depressive disorders. So in that case, stem cells can be an effective way to treat the atrophy of the hippocampus. Now, how does that work? Stem cells such as HPSCs or the human pluripotent stem cells can self-renew and differentiate into specialized tissue types, making them useful in regenerative medicine. The two most widely used subtypes of human pluripotent stem cells include the human embryonic stem cells, which are of course derived from the embryo, and the human induced pluripotent stem cells. Like these are the cells in which the property of pluripotency is induced. It's not natural, but it's induced by humans, of course. HESCs are obtained from the blastocyst of the growing embryo, as I also mentioned before, whereas the HIPSCs are generated from the somatic cells. It can be derived from any other cells, and pluripotency is induced in those cells. Now, stem cell therapy for post-traumatic stress disorder has been studied in the brains of rats, in which human-induced pluripotent stem cells were differentiated into the neural progenitor cells, which means that the induced pluripotent stem cells were then specialized to form the progenitor cells of the neurons, which would again form the neuron. Now, neurons, as we all know, have a peculiarity that they do not divide on its own. But the progenitor cells can divide and give rise to specialized tissues. The induced pluripotent stem cells derived neural progenitor cell transplantation was shown to promote regeneration and functional recovery after a post-traumatic stress disorder in rats. So we are considering the rat model. Now, again, as I mentioned before, that the post-traumatic stress disorder helps, it leads to the atrophy of the hippocampus. A mechanism needs to be studied that how it does so. Now, there are two different types of cells which are most important, which I would like to mention over here. The first one is the GFAP, or the glial fibrillary acidic protein cells. Now, these cells are the members of the intermediate filament family of the proteins, which form the network and provide strength and support to the cells. Now, the major function of the GFAP cells is to provide strength and support to the cells. The second group of cells is the BDNF, or the brain-derived neurotrophic factor. Now, what do these cells do? The BDNF cells promote survival of the nerve cells by promoting growth, maturation, and maintenance. So, as I mentioned, BDNF is very important for the survival of the nerve cells, which is of course by promoting growth. Growth here means of course the elongation and other stuffs, because neural cells or the nerve cells do not divide. Maturation, like from the progenitor cells or the precursor cells to the mature cells, and the maintenance, which can also be seen like protection from the external barriers, as I already mentioned in the neuroimmunology part. Now, what happens in the PTSD is that the GFAP cells as well as the BDNF cells decrease in number, which means less protection for the neurons and the support structure, which leads to the hippocampal neuron injury and ultimately the atrophy of the hippocampus. Now, the stem cell therapies have worked beautifully in case of the rat models, is that the astrocytes in rats with PTSD have manifested the morphological alterations, including a change in the cell polarity towards a more fusiform shape. The animal model have showed efficient differentiation of iPSCs into NPCs, which is the neural precursor cells, and the glial cells in vivo, which means, of course, inside the body, to replace the damaged hippocampal neurons. The transplanted cells enhance the expression of the mature neurons. The cells also overexpress the BDNF and the GDNF cells. Sorry, the GFAP cells. There is a typo in the slide. BDNF and the GFAP cells. The neurotrophic and the neuroprotective factors, which suggest the potential for the further neurogenesis capability. And I personally believe that it can be a future for patients with PTSD and hippocampal atrophy. Next slide, please. So that was all from both of us. Thank you for a patient listening, and any questions are welcome from you. Thank you.
Thank you, Mr. Singh.